The correct level of fluid resuscitation can avoid patients developing conditions such as shock, multi-system organ failure, acute kidney injury, and death. However, there is the risk of under or over resuscitating burns patients. Hodgman et al. The amount of fluid given to a burns patient is based on the degree to which the patient has suffered burns. Government et al. Conducted a study in 50 pediatric burns patients and discovered that their total body surface area was either over or underestimated, which led to the incorrect amount of fluid resuscitation given. It was discovered that 94% of the time, the patient's total body surface area was overestimated. Additionally, 59% were given more fluid than necessary. A study in 2007 found similar results, adding that in rural areas, smaller burns were overestimated and over-resuscitated. Freeberg, Ignory, and Sataroli. There are adverse effects to over or under resuscitating a burns patient. A study by Klein in 2007 discovered there was a positive relationship between increased fluid administration and the risk of patients developing complications such as bloodstream infections, multiple organ failure, respiratory distress syndrome, or even death. Recently, a concept called permissive hypertension has shown surprising results. The goal of permissive hypertension is to minimize fluid resuscitation while still maintaining vital organ perfusion, avoiding cardiovascular collapse, and keeping the arterial blood pressure relatively low. Wilson et al. Explain the aim of permissive hypertension is to limit the loss of red blood cells and minimize arterial pressure on the hemorrhage until surgical control of the bleeding can be achieved. Often in hypovolemic shock, paramedics will use 0.9% sodium chloride to increase fluid volume and blood pressure. This has been shown to dilute the blood and lower the red blood cells, which can inhibit the body's ability to effectively transport oxygen and clotting agents. Tintinali-Stapsky. Dutton, McKenzie, and Scalia have even suggested that in some cases, no fluid should be administered for patients in mild to moderate hypovolemic shock that is the result of an acute hemorrhage. In 2011, a study of patients in hypovolemic shock from penetrating torso injuries found that delaying fluid resuscitation until surgical interventions could maintain homeostasis resulted in an improved survival rate. Dutton et al. It appears for patients who are able to adequately compensate for their blood loss, withholding fluid therapy can have a positive result. Even in septic shock, the evidence shows that where fluid therapy is concerned, there is little to no benefit and possibly even negative long-term patient outcomes. Yearly et al. A study by Yearly et al. In 2014 of patients with sepsis had interesting results. It showed that patients administered with 2.3 litres of fluid therapy instead of the average 2.8 in the first 6 hours had a 3.2% reduction in mortality. The same study also showed a 3.4% increase in renal failure for the study group administered with the higher amount of fluids. 3 later studies on early interventions for sepsis showed similar mortality rates even though the fluid therapy had been reduced for 1 litre for the first 6 hours. Osborne 2017. Consistently when it comes to fluid therapy, the evidence tells us to err on the side of caution, considering the extra cost and extra time that needs to be spent gaining intravenous access. In some cases, it would seem unjustified.
Created using Powtoon.